My dear friends, I am Dr. Jayaraj, nephrologist working in Central Kerala, attached to a 350-bedded multi-speciality hospital. Today, we are planning to present the importance of loop diuretics in the management of chronic kidney disease. The chronic kidney disease is a worldwide problem, has been recognized as a leading public health problem. The global estimated prevalence of chronic kidney disease is 13.4%, between 11.7 to 15.1%, and patients with end-stage kidney disease needing renal replacement therapy is estimated between 4,900 and 7.083 million. Chronic kidney disease is a very slow, insidious disease. From the normal situation, it progresses. But there is a possibility that even if it increases to a certain extent, there is a possibility of reversal. So CKD risk reduction is important, and screening for CKD is very, very crucial. Now, screening for CKD will be including the glomerular filtration rate and the proteinuria together. Then only we can really estimate the progression of the kidney disease. So the increased risk produces more problems, and then actually this dotted line shows that there is a possibility that even the damage occurring can be to a certain extent mitigated and reduced. But progressively, when it comes to a reduction in glomerular filtration rate, the estimated progression, treat complications, prepare for replacement, etc. Once the patient goes into kidney failure, that is the stage 5 CKD, the replacement by dialysis transplantation, there is no chance of any reversal. So that we have got three categories. That is, one is the etiology, whether it is a diabetes, hypertension, primary renal disease. Then the prognosis by the glomerular filtration, that is from G1 through G5. Depending upon the reduction in the glomerular filtration rate, it becomes more and more severe. And of course, on top of which there is a heat map of the proteinuria added. So even a mildly increased proteinuria can produce problems later on. So there is an interconnected relationship between acute kidney injury and fluid overload. Now the fluid overload produces edema. The pathophysiology of chronic pressure overload, this is actually what is happening in cardiac failure. Progressive volume overload, cardiomyopathy, ischemic, non-ischemic, all leads to a reduced left ventricular ejection fraction, and the outcome is a progression of chronic kidney disease, heart failure, hospitalization, sudden arrhythmic death, pump failure, etc. Even before the primary kidney disease worsens to a stage 5 CKD, there could be a possibility that the patient can develop a cardiovascular complication. So once the patient's disease progresses, the conventional diuretics may not be effective, which actually controls the hypertension, etc. So the loop diuretics will have to be used. Now, the role of loop diuretics in chronic is the extracellular fluid volume increases by up to 30% in patients with advanced CKD and severe edema. Loop diuretics are recommended diuretics for patients who have an estimated glomerular filtration rate of less than 30 ml. That is when the patient reaches the stage of probably stage 4 disease, stage 4 CKD, because other diuretics, including thiazides, are less effective in advanced CKD. Is the kidney disease improving global outcomes directive? And when we think about diuretics, especially loop diuretics, the thing that we have got better response with torsim. Actually, furosemide is the drug which we are all familiar with and we have been using it right, left, and center. But when the torsemide is available, probably it as an oral diuretic, this is have got definitely a better response as far as furosemide is concerned. This is because torsemide is 80% is metabolized through liver and 20% only the renal. So even with fairly advanced renal disease, this could be effective because it can actually be metabolized through the liver. Whereas furosemide is 50% renal, it's an unchanged excretion, and here also 50% renal conjugation, which probably when you have got a reduced glomerular filtration rate, this does not happen. And torsemide's half-life is relatively unaffected by the renal dysfunction, and furosemide's half-life is significantly increased in renal dysfunction. Another thing is loop diuretics directly inhibit sodium potassium to chloride co-transport system in the inner ear and needed for the maintenance of homeostatic endo-lymph fluid ionic balance, so that furosemide is metabolized by the kidneys and thus in renal dysfunction, furosemide will accumulate, increasing the risk of ototoxicity. And torsemide has got a 4 to 5 half-life, whereas furosemide is only 2.8 hours. So the longer elimination of the T half leads to longer duration of the effect of the drug. Significantly greater diuresis and natriuresis versus furosemide in advanced renal failure. When you compare, there is 20 patients with advanced chronic renal failure were pre-treated with furosemide 500 milligram for 13 days and then randomized to 3 groups: torsemide 100 milligram, torsemide 200 milligram, and furosemide 250 milligram for 2 weeks. And at the end point of day 28, the volume of urine was 1690 in furosemide group, whereas it's almost 2.5 liters in the torsemide group. And of course, the sodium excretion also concurrently is much better as far as torsemide is concerned. So greater natriuresis versus furosemide in chronic renal failure and better edema management. So study 1 showed that body weight has reduced by at least 4 kilograms in 61% of the patients. And for study 2, peripheral edema was abolished in 77% of patients. So lesser risk of hypokalemia versus furosemide in chronic renal failure. At times in advanced renal failure, you can even expect a higher potassium levels. So sodium significantly increases this. So of the treatment of chronic renal failure, so torsemide is daytime collections and nighttime collections definitely is significantly better with torsemide. So urinary output increased in the first 2 days with torsemide treatment. And blood pressure and body weight significantly decreased during torsemide treatment in chronic renal failure patients. So summarizing, chronic kidney disease is defined as abnormalities of kidney structure or function present for more than 3 months with implications for health. And studies have shown the prevalence of chronic kidney disease ranges from 0.78% to as high as 17%, with the incidence is 151 per million population. Loop diuretics are recommended diuretics for patients who have an estimated glomerular filtration rate of eGFR of around 30 ml per minute in 1.73 meters squared, because other diuretics, including thiazide, are less effective in advanced CKD. And torsemide is safer choice in patients with renal insufficiency, longer duration of action, significantly better diuresis, and better edema management with torsemide. The most important thing probably will be whenever we switch from an injectable loop diuretic, say furosemide and torsemide, if you're using it as an injectable preparation, the absorption from the GI tract is not considerably affected because we are giving it as a parenteral injection. But when it is switched to the oral, definitely torsemide has got a better availability. So lesser risk of hypokalemia versus furosemide in chronic renal failure. Thank you very much.